Hi, I'm Dr. Gerald Deas. Welcome to Health Center of Downstate Medical Center. Today we're going to talk about a very important subject matter, anesthesia. I remember when I was a youngster, I had to have my tonsils out. They took me to St. John's Hospital and they had us all sitting on a gurney with little gowns on. Mommy and Daddy wasn't around, nobody was around, and they were going to take out your tonsils. Well, you can imagine how frightened little children would sit there. They didn't know what was going to go on, you know, but all of a sudden it was your turn. And they took me in and they gave me some ether. It was like a drop ether, you know, to put you out. And next thing I knew, I was back in the bed with a throat that was very sore and had my tonsils out. First time I ever had any kind of deadening thing of the body. But as time went on and I got into medicine and people had to go to surgery and things like this, they had to be anesthetized. They had to be put to sleep in many different kind of ways, whether it was a spinal or whether it's the gases and things like this. And when you think about it, how magnificent that is when you can go to sleep and have something working on you. The pain fibers are still there and so forth, but you're asleep. And when you wake up, you're in the recovery room. Well, the anesthetist, that person that puts you to sleep. When we had a dog lab here, we had 4 people on a dog. And each time we did an operation, one had to become the anesthetist. And that was the most difficult part of the whole operation, because if that dog died, you know, as such, from you overdoing something, your mark was based upon those kind of things. So basically, I found that the most intriguing part of that whole surgery was giving that dog anesthesia. And so today we're going to talk about that and talk about you might have had experiences yourself already, but we have a doctor here who is an anesthetist, a nurse anesthetist, and we're going to get into his whole field and how the next time you're going to have surgery, how you might feel better after listening to him. Welcome, Joseph.
Thank you. How are you?
So nice having you with us today.
Yes.
You know, I see you around Downstate Medical Center, and I said, I got to show folks off who this person is. You know, you're not just wandering through the halls. You're doing something more important than that. But maybe this would be a little your background. How did you start off in becoming an anesthetist?
Well, the history is that my mom was a nurse.
Oh, okay.
And she was trained in London.
All right.
And then she came here. And then I decided, I was looking at various careers. And the thing that appealed me about nursing are the various avenues you have. You know, if you're tired of pediatrics, you can always go to another area.
Sure.
So I went to nursing school. I trained at Long Island College Hospital, that School of Nursing.
Right.
And then my first job, nursing job, was at Cornell.
Okay.
And I worked in the pediatric adult burn ICU. And there I worked as a staff nurse for 2 years, and I moved up to assistant head nurse, where I ran the night shift, and I was responsible for a 20-bed ICU along with overseeing the step down.
Boy.
So, and in being in charge, along with the resident or fellow who's on that night, I had to coordinate movement of patients when trauma would come in.
Boy.
So I did that, and I wasn't satisfied.
Okay.
I needed something more to do. So then I began to look at the advanced practice roles of nursing. There was the acute care nurse practitioner, the family nurse practitioner, and then the nurse anesthetist.
Right.
And to tell you a little about me, I don't like to do what everyone else is doing.
Okay.
I like to do what the minority is doing, because everyone at that time, all of my colleagues at that time, were becoming FNPs, were becoming acute care nurse practitioner.
I see.
And I said, what's with anesthesia?
Right.
So I looked into it more and more, and it appealed to me because I think the great thing about anesthesia, as opposed to being an NP or an acute care or working in a unit, is that you devote all your attention to one patient.
Right. Oh, yeah.
That one patient gets your undivided attention.
Oh, yes.
And you are using all your knowledge, all your skills, all the art that you've learned to care for that patient.
Yes.
And it's actually a step above critical care. Because when you think of it, you're managing them hemodynamically, you're looking at their neurological status, you're looking at their renal status, their endocrine status, everything as an anesthetist, you are responsible for that patient.
That's an awesome job.
It is an awesome job.
And especially when you have to do it every day. I mean, you know, people have a job that's hard, but they get a little reprieve sometimes.
Right,
you know?
right.
But when you have to face not just one patient, but many patients in a day, that is something else, I would tell you, because like I said before, the hardest thing I saw in dog surgery was giving anesthesia.
Yeah, yeah.
You know? and doing it well.
Yes.
You know,
as they say in anesthesia, we have the power to bring a patient close to death and bring them back.
That's right.
And that's why the responsibility we have as anesthetists is such a great responsibility, and it's nothing that's taken lightly.
Right.
You know, we are highly regarded amongst the advanced practice nurses. We are highly regarded in the medical field because of what we do and the knowledge base and the expertise and the skills that we bring to the profession.
Oh, yes. You know, I've known several African-American anesthetists during my time.
Yes.
But there was one here at Downstate in Kings County that was so superb that heads of departments or surgery or medicine, if they had a relative that was going under anesthesia, he was the one that was going to give it.
Yes.
They didn't care whether you had an MD, PhD, but you're going to get that anesthesia.
Yeah.
They're going to pick the best one.
Absolutely.
And he was the best.
Yes.
You know what I mean? You would think, and you know, medicine is a funny thing. You talk to people and you make diagnoses, but you don't really control their life situation.
Yeah. As we do in anesthesia.
And as you do in anesthesia, it's the greatest respect I have, because you just don't go and show up at the operating room. Give us, well, even before that, with your mom being a nurse and how that affected you being a nurse. Male nurses, why are so few of our, even African young men, not becoming nurses? It's not all medical schools or this or that. It's something, if you really want to help people, it's in the medical profession.
Right, yeah, and you know, I've spoken to some of my applicants who told me that they had a love for nursing, but because of the whole stigma associated with it, like nursing was traditionally a female profession.
Oh, sure, sure.
Predominantly female, and it was...
Florence Nightingale.
Yes.
You know, but around the great poet out of Brooklyn, he was a nurse during the Civil War. I'm drawing a mental block now, but he was a great poet. He became a nurse during the Civil War. It was a male, you know. But continue.
Yes, so, and dealing with that as well, and even in the nursing profession itself, men were not readily accepted.
That's right.
The association, the American Nurses Association, did not really readily accept men.
Right.
And it was in anesthesia. And we still had our struggles there in anesthesia, but we're greatly respected, greatly regarded there.
Right,
so those are some of the struggles that the generation from probably the 60s and 70s associated all the stigma with going into nursing. What we're finding now, though, is that more males are entering the profession.
Oh, yes.
And it's good for the profession. I mean, not to bash nursing, but I think that as more men come into the profession itself will receive much more respect and will have a much stronger voice with men coming in. And the areas that men tend to gravitate to are critical care, psychiatry, and emergency room.
Right, right. But as I see them, they take those positions so seriously, and they're so proud.
Yes.
You know, when you have something that you know you can do.
Yes.
And nobody can tell you that you're not doing it.
Yeah, that's true.
There's a certain amount of pride you have there, you know, and so, and it's not being I know it all, but it's just that males could even respond sometimes to a male nurse more than they would, or even a female nurse, in what they're discussing.
Right, absolutely.
You know,
and there have been instances where, and I've seen this even in my own clinical practice, where when I was at the bedside, where a more senior nurse would say something to a male physician and he would not listen to her.
Right, yes, yes.
But then I would go, and I would be the junior one, and I would go to him and say, so what do you think about this? Maybe we should do this or try this. And he said, okay, Joe, sure, let's go ahead, let's try that. So, I mean, there's a lot of dynamics that goes on in the profession between nursing and medicine. Yeah. And I think as male come into the profession, some of those barriers will begin to break down.
I think so. And
yes.
I think it's wise because when we talk about unemployment,
yes.
There's going to be a lot of employment necessary for males to come into nursing.
Yes, absolutely.
And it's a wonderful profession.
It's a wonderful profession.
It's a well-paid profession today.
Yes.
You know,
well-paid, job security.
Job security.
I mean, we have our fluxes with when the market may be flooded or there may be shortages.
Right.
But overall, you're a nurse, you can guarantee you'll find a job.
Right, oh yes. Now coming here at Downstate, how long have you been here at Downstate now?
As an administrator, I've been here since October 2006.
All right, right.
So it's roughly 5 years.
Yeah, and now you're taking more of a leadership role, I imagine.
Yes, yes.
Yes.
I actually trained here. I did my
Okay.
education here in my master's
Right.
as a nurse anesthetist. I graduated. After I graduated, I worked as a clinical coordinator at Kings County.
All right.
Where for a year I oversaw the training of the students there.
I see.
And then I left and went to Jersey to do open heart, get some
Okay.
open heart experience, and then I returned to the city. And then in returning, I took a more leadership role.
Well, that cardiovascular operations, being a nurse there, I imagine that is a stressful situation, given the anesthesia to people working on that heart.
Yes, it is.
You know, because the only thing you have is that drape there looking at that patient, you
Yeah.
know, and everybody else is working on the other side of that drape.
Right.
But you're looking at many, many things at the same time.
Many things, yes.
They are looking at what they're doing structurally. You're looking at the patient breathing.
Right,
you
right,
know?
right.
And it's much more complication than the patient breathing.
Yes, there
than
is.
it is in suturing, cutting, and things like that. So I imagine there have been operations that you had to maybe stay on the job for 6 hours straight hours sometimes.
Yeah. There's some heart cases that go on. A traditional heart case will take maybe 4 hours.
Right.
But there's some cases where the patient is so sick, or there are complications. You can't get them off bypass. You know, the valve isn't working. The left ventricle isn't working as well. And then you're putting on other things, a balloon pump, starting nitric, and it can get very complicated and stressful. And sometimes when I leave, I'm more mentally exhausted than physically exhausted.
That's right. You know, and sometimes you don't have someone you can call in to take your place.
No.
You know, especially a heavy trauma hospital like even Kings County Hospital.
Yes.
Where you call all the time.
Yes.
I'd imagine it has its stresses there.
Yeah.
Yeah.
That was very
Now,
stressful.
are you attracting many of the African Americans into anesthesia now?
Well, that's a question that the association is trying to deal with.
Okay.
Because what happened is we have over 105 programs.
Wow.
Of the 105 programs, there are 3 African American directors.
Oh, wow.
Myself, one in Michigan, and another one in Chicago.
Boy.
And the challenge that the association is facing that was brought up to the association by students was that the body needs to reflect the community which we serve.
Sure.
We serve a diverse community, so our body should be diverse.
Surely, surely.
The challenges that programs have is that the faculties can be all white, or you may have a few minorities. And when you have minority students come in, they really have no one to identify with.
There you go, surely.
And that's the challenge they have.
That's
The good thing we have here at SUNY Downstate is that the College of Nursing is a diverse college with a representation from all ethnic groups. And the program itself, currently the faculty now is all African American.
Wow, that's
which is very unusual
when
you look at other programs because they're generally mixed.
Yes.
So we have a large percentage of minorities applying. But the challenge that I face as a director and selecting candidates is that they're lacking.
Okay.
They're lacking. The GPAs are not as competitive as I would like them to be.
I see. When you say GPA, you're meaning what?
The cumulative GPA from college.
College, okay,
yes,
right.
from
right.
the college.
Surely.
It's not high.
Right.
And one of the things that I've done with my students is visit some programs and begin to speak to them about the importance. And what happens with a lot of students in college, they don't think about the future.
Yeah.
They think about, I'm getting my associate degree, I'm going to get it and go out and work.
Right.
But they don't think about 4 years or 5 years down the line when, you know what, I've gotten that associate, I've gotten that bachelor's, I want to go on to get my master's.
Right, surely.
And that's when it haunts them.
Surely.
Because when we look back at the history, they did very poor in the associate. Now, mark it, we do have some African Americans who have done exceptionally well,
Right, surely.
and who've gone through the program and done exceptionally well.
Right.
But I would still like to see more apply.
Yes.
Okay. Right now, our ratio is about 1/3 African American, 1/3 Asian, 1/3 white, and maybe 1% or 0.5% Hispanic. So I would like to see more African American, more Hispanic applying to the program.
Right.
And, you know, taking on the challenge and
Right.
representing our group in the profession. We are the smallest representation
Right.
in our association.
Well, you know, when a person is going to undergo surgery, what is your position before you even see that patient in the operating room?
Okay. Well, the first thing I would do is just review the history.
Okay.
Look at what type of surgery they're going to have,
Right.
and review the history. Look at whatever other disease they have,
Right.
high blood pressure, diabetes,
Right.
and look at that. And then I would begin to formulate what plan would be ideal for this patient,
Wow.
how best to put this patient to sleep.
Yes,
Okay.
right.
Then the next thing would be to actually meet the patient,
Okay.
because that's very important. And I want to say the kind of shortcoming of anesthesia is that we really don't have, we don't spend, like medicine can spend 3 weeks to get to know their patients.
Right, sure.
We have maybe but 15, 20 minutes to get to know that patient, develop a rapport with that patient,
Right.
bring that patient at ease before we bring them into the operating room. And that itself is the art of anesthesia.
There you go.
Apart from the science.
Yeah.
Because you have to be able to look at a patient and say, you know what, he's very anxious. As soon as I get into the OR, I may have to give him some Versed, give him something to help him to relax.
Right.
And then begin, and we're constantly talking to them, answering their questions. I mean, sometimes I have the opportunity to see them the night before.
Yes.
And I would tell them, listen, I have my set of questions to ask you. You know, if at any time you have any question, don't be afraid to have me page or write it down, and in the morning
Right.
we will sit down and answer your question. Because for us the important thing is we don't like a patient to go to sleep anxious and with anxiety, because it affects their entire anesthesia course.
Oh, sure.
We like them to go to sleep comfortably.
All right.
You know, and we always tell them I always tell them when I'm putting them to sleep, think about someplace pleasant, your vacation, on the beach, you know, with your loved one, and that tends to put them at ease.
You know, that's a wonderful feeling. I think there are more doctors who are not anesthetists should be able to have that kind of quality.
Yes.
Because white coat hypertension is real.
It is.
All they have to do is see a white coat and blood pressure.
Yes.
Like that, you know, the whole systems are shifting around just on the basis of the emotions.
Yes.
And we're not taught how to deal with emotions.
Yes.
You know, everybody that comes into medicine are not doctoring. I mean, you know, a lot of times just their personality is not there.
Yes.
You know, and so, but just having a person to come in before, like you were just saying, to make them feel comfortable.
Right.
You know, they talk about 15 minutes for an examination. Very seldom you can make a person feel comfortable in 15 minutes. But if you could take at least, I always used to tell my residents, 1 minute is a long time if you do it in quality.
Yes.
1 minute. You can do a lot in 1 minute. But if you do that minute like that, and they suspect that you want to get away from
right. They're very perceptive.
Very
Patients
perceptive.
are
They're
very
looking
perceptive.
at you, you know, and you got to put your hand on that patient. I find doctors don't even like to touch patients
Yes.
today.
Yeah.
You know, you'll see them put the stethoscope on, but you never see them now put their hand on the shoulder
Yes.
of the patient. Yeah. Touch. In fact, there's a Dr. Dolores Krieger who taught therapeutic touch
Yes.
at NYU. And therapeutic touch, this body of ours is nothing but electrons.
Yes, it is.
You know, when you think of the brain sending off its waves through a thick skull, picked up by a machine, there's a whole aura around that patient.
Absolutely.
Now, when you enter that aura, you can either calm it down or make it really,
yes,
just like that.
Yeah.
Just by a smirk or an attitude.
Yes.
That transference is powerful. When I talk about anesthesia, I go back to our motherland. Man, they were doing stuff, or take acupuncture, for example.
Yes.
I mean, you can press here and put somebody to sleep.
Yes.
You know what I mean? You know, you do certain things, or just a touch, just putting a needle somewhere, just a prick of a needle can make a whole change. So you can imagine your whole department as being a anesthetist and putting somebody to sleep, and they've got their faith in you.
Yes.
And how you have to get that thing together in a few hours, maybe, or a few moments.
Yes.
For that person to
and
go.
And I think that's, as nurses, we bring that to the profession, because as nurses, we are trained to touch our patient. We are trained to be able to have a patient who is admitted to your floor, got a bad diagnosis.
Right.
We're trained to be able to bring them at ease. And as an anesthetist, all that training that I had as a nurse and experience that I've had as a nurse at the bedside, I've brought it with me to the bedside of my patient who's going for anesthesia.
That's right. And you know, maybe that's why a lot of people are not drawn to anesthesia, because to become an anesthetist, they don't have that kind of quality of deportment and voice, facial things. You know, people will read your face. I have a whole book. I have a whole book on this woman who talked how they look at the face. One thing you have never seen is your own face. You look in the mirror, you see an image of your face.
Correct.
But you haven't seen your own face, even looking in the mirror.
Yes.
I see your face now, you see my face. But you don't see your face, how you interpret yourself.
Right.
So I think sometimes there should be training in that face as much as giving the anesthesia. I don't know if there's a course in that and so forth, or do you recognize it? Do you reject sometimes people who want to become an anesthetist? They say, this might not be your field.
Yes, that's the challenge we have in interviewing, because most of the anesthesia program, we have a face-to-face with our applicants. And that gives us the opportunity to kind of decipher, is this person entering this profession for the right reason?
Yeah, right.
Because they care, or because they want to move to a higher level, or is it for financial gain or other things of that sort?
Yes.
So we do look at that.
That's right.
And you'll be surprised at what some applicants will say at an interview when they think they're all relaxed, and it will just set an alarm off in our heads that, you know, this is not the one.
Well, time is always our enemy, and we have just 2 minutes. What would you suggest to the patients who might be looking at here, or the people looking at here, what they should suspect of the anesthetist when they come, if they should have to undergo surgery? What things would they look for in an anesthetist?
Well, you want someone who has a full understanding of the surgical procedure and who can tell you what the various options are as an anesthesia, as far as regional, local, or do you need general anesthesia, to discuss that. You also want someone who is sensitive to you and who will listen to you, because sometimes patients are saying things to us and we are just so caught up in what we need to document, what information we need to get, we don't listen to them. So someone who knows the surgical procedure, can give you the options and be honest with you about the options, and someone who is sensitive to what you're saying to them and can able to pick up your cues.
Well, it's been a pleasure to have you.
Thank you.
And I hope you folks out there, if you have to undergo surgery, and I hope you have listened to this program. And I know Joseph Deas is certainly busy all the time, but he certainly, if I need anesthesia, I certainly would want him to be my anesthetist. So take care of yourself. But if you do have to have anesthesia, choose him carefully or her carefully. And you can reject. If you don't feel comfortable with one, you can say, well, I don't feel comfortable with that particular person, and they'll have to change it. So I'll see you the next time. I hope you don't have to have an operation right now. See you later.